Good afternoon, everyone. I would like to thank Amrinder sir for giving me this opportunity. I will be discussing retinal vascular disorders. Diabetic retinopathy has already been discussed. I'll be touching upon mostly on BR view, CREO, and few cases of PAM and optic nerve head. So these are the cases which we usually see in OPD, and mainly concentrating on BRVO because the second most common retinal vascular disorder after diabetic retinopathy. And we have an acute phase and a chronic phase. In acute phase, what we see are the hemorrhages, the soft exudates, hard exudates, tortuous veins, retinal edema, and distribution of S-shaped distribution of the retinal hemorrhage around the vein occlusion. The FA findings which we see here conventionally sees a delayed filling, but most of the time it's occluded because the obscured because of hemorrhages. And in chronic BRVO, what we see is the vascular abnormalities which develops along the distribution of the vein, and there are collateral formation, microaneurysms, and telangiectatic vessels which are there. On FA, there is capillary non-perfusion and the leakage of neovascularization. Now, what OCTA helps in BRVO cases, it clearly demarcates the territory involved and shows the presence of even the macular ischemia which is there. And neovascular patch, if there any, it can easily demonstrate and show you that's there. And even the depth of ischemia, the superficial or deep, the structural image will show you. I'll show you some cases which clearly demarcates it. And even if you want to laser those sector for a BRVO, it will give you a complete, the montage will give you a area where you can actually laser. It's a complete non-invasive, and even you can follow up the patient's post-treatment on Octas. So this is a case, a first case which I'll show you. It's a supratemporal BRVO, and you can see. Can I have the pointers? So this is a supratemporal BR. You can see the multiple areas of capillary non-perfusion which are there, a big area here. And you see superiorly, these are the small neovascular patch which has been developing in these areas. So you can counsel the patient and ask the patient to undergo laser or anti-VEGF injections. So this is an interesting case which came up. That is a 74-year-old hypertensive male, and he came with a history of scotoma in the right eye. On examination found out to have a small branch in occlusion, and he said the left eye also has a diminished in past 6 year, past 1 year, and what you saw was an old BR view which was there with a huge area of macular ischemia, and it was around 612 vision. And since there was no macular edema on the right eye, so there was no anti-VEGF injection which was given. But when the left eye was subjected to a montage, you see a huge area of non-perfused area which is there, and this patient was subjected to a PRP, a sectoral PRP laser. There's a third case with a elderly female which presented to us BRVO, the inferior temporal BR which is there. And you see the multiple areas of non-perfusion which are there. And she was advised to undergo a sectoral PRP because more than 5 disc diameters of non-perfused area was there. And this is a case where we have a follow-up of 3 years on OCTA, and which demonstrate how the disease progresses. So this is a 60-year-old female who came with the history of this decreased vision in the left eye. Past 2 days, she was observing some black areas which were there. So on examination, we found out these are the collateral vessels which were there, and this is the whole inferior temporal area which was completely non-perfused. And if you see the structural OCD, we see inferior there's a neovascular patch which is there, and if you see the structural OCD, there's also the deep vascular layer which is ischemic. If you compare the superior and the inferior, you can see the difference in the grading of color. It is more dark, which shows the extent of ischemia which is there in the deeper layers. So on doing a 8 by 8 scan, which can see clearly the macular ischemia, which is the extent of macular ischemia, and the collateral vessels, which has developed there. So the patient was subjected to multiple anti-VEGF injections and multiple sittings of sectoral laser, and this is how the patient presents after 2 years. So you can see, if you see a small area of neovascular patch, after 2 years, it has advanced to a big neovascular patch, and which is very easily being documented here. Even these areas which are there, these are the areas of vitreous hemorrhage which presents as black areas, and some areas of newer neovascular patch which has developed in due course of 2 years. So the patient was again subjected to PRP augmentation and anti-VEGF injection. And you can see when the vitreous hemorrhage cleared, what we saw was these big patches, which were again, you see here, this was the previous, and after 1 year when the patient again presented to us was, these neovascular patches are completely increased, and these patches which were small before has increased. These patches has regressed, but you see these patches, they are increasing in size. So this is a way to document the disease progression. You can also explain the patient how the disease is progressing. So the patient again was subjected to anti-VEGF PRP lasers augmentation, and you can see after anti-VEGF PRP how these neovascular patches they actually regress, and you can actually demonstrate. You see this big patch has gone down, this patch has gone down, and it's a very beautiful way and non-invasive way to document these changes. And in 3 years, what we see, this was the on presentation, the macular ischemia and the collateral vessels. On after 3 years, uh, these areas are still there, but what we see is this line on structure. This is the formation of ERM which is being taking place in this patient, and you see this dragging of macula is there. Still, some of the patient is maintaining a 6/12 vision, and she doesn't have any major visual complaints. And an entity which which I'm going to cover is PAM, which is a paracentral acute middle maculopathy. It is a diagnosis which has been proposed on SDOCD. So on SD, there's a capillary retinal capillary non-perfusion ischemia which is there, and it could be a precursor to maybe a CRO or a CRVO which is there. What we see is the hyperreflective bands on OCD, which are seen in the internuclear layer, and the outer retinal layer is completely spared. So this is a 54-year-old hypertensive male which presented to us with the stereoscotoma which was there, and what we saw on if the outer retinal layers are completely spread, but we see the inner layer they are patchy or the hyperreflective bands which are there in the inner nuclear layer, but the outer layer is comparatively near about normal. What we saw on ONFAS OCTA was you see the larger vessels they are completely fine, but what we saw is the small capillaries, these are whitish patch which are present over the posterior pole, and these are the capillary non-perfused areas, which are the feature of PAM. So this patient was diagnosed as PAM, and he was kept under observation. Luckily, these regions resolved, and there was no other complication which developed. And what we saw, because we know the PAM is a disease of outer inner layer, so the superficial layers were completely normal, but what we saw was the deeper layer, which is completely non-perfused, no clear demarcation of inner retinal vasculature is seen here. In case of CRU, when the patient usually presents to us, it's the macular edema which is there, the central edema, and which is the cherry red spot is there. So even if you scan the central area, the vessels won't be clearly visible. So what we do, so this is a case I will show you. A 69-year-old male presented was decreased vision in the left eye since one day. He was already given ocular massage and a AC tap before when he presented to us. And what we saw was the CRO in the left eye, which is there. You can see the typical presentation of CRO and OCD. And when we did an OCD angio or the optic nerve head, the optic nerve in the right head, you can see the vessels are there, the capillaries are there, the clearly perfused. But what we see, the left eye, the disc, and the small vessels, they are completely obliterated, or they are not actually very well seen on day of presentation to us. And 7 days after presenting to us, the patient developed a myocardial infarction, and he went angioplasty. So after 1 month, when he presented, he came back to us. The edema has gone down, but visual acuity has improved to half meter finger counting. And we all know that after CRO, within a week or more, there's a recanalization of the vessels. The perfusion starts after a week. So how to document that perfusion? So what we did an ONH angio again. So this was on presentation, if you see these vessels, and this was after 1 month of CRO presentation. You can see these capillaries. These are now visible, and their perfusion is slightly better. Maybe not normal, but slightly better than what was there on the day of presentation. And we can document these small capillaries which are now visible. But again, the right eye was completely normal on that. So one small, okay. Yeah. So concluding the OCTA, even in vascular disorders, is really good tool, especially in documenting the progression of the disease. And you can actually tell the patient how the disease is progressing, and it might need previous repeated treatment, the lasers on the injection, and you need to counsel the patient as per those indications. Thank you.
Thank you, Dr.